the request to the broken facility.
Hello and welcome to the Fitz and Healthy podcast. I am your host, Dr. Lauren Fitz, and I am joined by my beautiful co-host, Cinthanie McAllister. What's up, girl?
Hey, girl, hey. That's our first Hey, Girl, Hey of 2018. Just putting that out there.
I know. It's crazy. It's crazy. So for listeners who possibly might be listening to our show for the very first time, the way that I sound right now is actually the best that I've sounded in all of 2018, but I still don't have my voice back, right? I went from having zero voice to having a voice like a dude to now I just sound like I can, operate a sex phone call service or something.
But even before that, you were like whisper song. Like
yes.
You were like whispering into you were sending us voice notes like, guys, I can't talk. I'm like, then why are you talking, Lauren?
Right.
But it literally made me think of the whisper song because it was so quiet. So quiet.
And that's so not me. I'm so the opposite of quiet.
It's so funny.
So we are here. We're actually a couple of days away from my birthday in January. So we're at the latter part, the second half of January. And this is actually our first one to film together for the year. And before we do the iTunes review of the week, I just want to give a shout out to everyone that made our 2017 successful for this new podcast. Because, we literally started May 1st, and the fact that we have almost 180 reviews and so many freaking downloads of our podcast, and we have already interviewed a few celebrities, and we got some good ones coming up. It's huge. And so just shout out to all the people that followed us through 2018. And we are here to promise you that we are going to continue giving you good stuff so that you can learn to be, to give you the knowledge so that you can be more Fitz and healthy. So, and I want to give recognition to both you and Robert too, because Robert's our behind the scenes guy. So very
He's
rarely,
our Wizard of Oz.
Yes, exactly. Very rarely do people get to see or hear his voice, but he is a very vital part of the show, making it what it is. And I just want to recognize both of you guys for thank you guys for making 2017 an amazing first year of this podcast.
Stop it some more. No, it was a good year. It was a fun, good year. It was a good start.
It was. And so, we are on the show, we cover all sorts of things. We cover anything from health, nutrition, fitness, medicine, lifestyle, how to be just a better person in general. We haven't done a medical one in a while. And you and I were talking and we're like, okay, what are we going to do? And I realized that I have so many people that private message me asking me questions before they go to surgery. And of course, the people that are listening can't see, but I'm wearing my scrubs that say Dr. Lauren Fitzgerald, Anesthesiology. And most people don't realize that that's my specialty. I haven't practiced anesthesia in a couple of years, but people always ask me questions before they go to surgery because this is the part that scares them the most. So today's episode, we're going to talk about going under. But before we get started, you have found an iTunes review of the week that's awesome that we want to read and give acknowledge to. So go ahead and read that for me.
All right. So this one is from Mandy2343. It is a 5-star review. And it says, wow, what an eye opener. My sister introduced me to these episodes over Christmas break. Wow. Talk about binge listening because this is exactly what I did. These two ladies are so fun to listen to with their vibrant personalities. They touch topics that really touch home and have given me the drive to do even more research on my own. Yes. I have learned so much in these episodes, and now I'm taking control of my health and my life again. 2018 is going to be my year, and I can't thank these ladies enough on their tough love, informational health episodes. Y'all are the best.
And there it is, the first chills of the month for the reviews. Awesome. Thank you, Mandy 232 or whatever number you were.
2343.
Something like that. But truly, we do appreciate every single person that leaves a review because that basically makes this podcast searchable. And in fact, shout out to our friend Chris Anse. We interviewed him within the first month, actually before the first month. He was one of our first episodes to be released about health insurance. And he sent me a text message yesterday and he goes, I love the fact that I just type in Fitz and automatically your thing is searchable. And that's
I
because
know.
people have left reviews. And
Yeah.
so just thank you to everyone, because it does take some extra time to go and subscribe to our podcast and leave a review. So we appreciate all of you guys.
And in doing that, helping us, have a bigger platform for our podcast equals us being able to find bigger people to talk to and bring to you and interview for you. So it's really a give and give relationship. We will give you information and you give us a platform in return, and it helps us help you.
Absolutely. Absolutely. So, okay. Today we are going to talk about going under. And you notice how I try to make that sound sexy?
Yes. You're trying to use every last bit of that raspy, sexy voice you got going on.
It's funny because so I have what's called reactive airway disease, which is basically like the step right before asthma. So when a person that has reactive airway gets a cold, they cough a lot. And so basically it's just like asthma. I mean, in fact, when I get a really bad cold, I will use an inhaler. It's been a long, long time since I've had to do that, but I cough because on the tiny level of the alveoli, I'm getting technical on you guys, basically the units of the lung, right? They basically spasm and make you cough. And so I lose my voice when I get a cold. And literally every time I lose my voice, people are always like, you sound like you could, run your own like sex phone line service. I'm like, I don't know if that's a compliment or not.
It just means you sound sexy, which sucks because like you sound sexy, so you want to talk more, but you shouldn't be talking.
Exactly.
Your voice is gone.
Exactly. Yeah. And I kind of need my voice. I'm just saying.
Yeah, just a little bit.
Just a little
bit. We
bit.
didn't record for 2 weeks because of your voice.
Yeah, no, it's crazy. And I mean, people that follow me on Facebook know that I do a lot of Facebook Lives, and I felt like I can't be myself because I can't talk. It's crazy. So, okay. So a lot of people already know this, but to the people that this might be listening to for the first time, I'm a medical doctor who hasn't practiced medicine in a couple of years, but my specialty was anesthesiology. And this is a specialty that I feel like 99% of the people in the world don't really understand what it is that we do. And I will say that because I was literally 3 years into medical school, almost with my own MD. And I really didn't know what anesthesiologists did until I did a rotation with them. But this is a topic that scares a ton of people that are needing to go under for surgery. Now, I'm curious, have you ever had surgery before? I don't think I know that.
Yes,
you have.
I've had surgery twice.
Okay.
I've had my tonsils removed when I was a kid, and then I had a benign breast tumor removed when I was like 18.
Okay.
So I've gone under.
You've gone under.
I have gone under.
It doesn't sound near as sexy as me. Yeah.
Shut up.
Okay. So you had anesthesia at, well, first of all, when you're a kid, you don't really know what to be scared of. When you were 18, were you old enough to know that you should be scared about anesthesia, or was it kind of just like, yeah, this is...
Well, I was still scared because like I think anybody going into surgery is like they're not comfortable. I mean, the idea of like you're not in control of your body essentially. Somebody else is in control of your body for you, aka anesthesiologist, and people are going to cut you open and you're not going to know anything about it, and then you're just going to wake up and you're supposed to be fine. So that is such a foreign like thing to think about, but like
it's crazy, right?
It's like when you get on a plane and you're up in the air and you're like, okay, I know I'm flying, but you don't feel it. You know what I'm saying?
Yes.
Same thing with surgeries. Like you're like, okay, I know I'm going to get cut open, but you don't experience it.
No.
You know what I'm saying?
Oh, absolutely.
So I was scared. I was really nervous, like, because I don't like needles, don't do well with needles, which is so funny because I used to be in the medical field. I used to work for an oral surgeon and help him like insert IVs and stuff. But when it's on me, I can't hang. I can't. So the anesthesiologist that I had when I had my surgery when I was 18, he was this older British guy, and he was so funny and so nice. Like he made me so comfortable. I didn't even feel it because he was just like distracting me and talking to me. So he was great. He was super great.
That makes me happy.
It made it a good experience.
That's
I know you
huge.
Don't you get y'all get some bad rep?
Yes, we do. Well, let's start off with the first bad rep. The first bad rep is that were terrible, like personality wise and bedside manner. And I will be the first to admit that. Like there were so many of my colleagues that I'm like, it's a good thing you don't see patients that talk to you back to you. I mean,
well,
like,
that's probably why they're anesthesiologists,
so.
because they can't talk. Their patients can't talk back.
And you know, like different strokes for different folks. Like pathology. Pathology is a specialty that literally, if you're a people person and want to be around people, you can't go into that because I mean, you're literally looking under a microscope all day. And yeah, for sure. But anesthesia isn't quite as bad as pathology, but it's definitely, it's funny because I love talking to people and I, you know, for the most part enjoy people, but certain people, and I didn't realize this until I got to anesthesia. And I'm like, there's a lot of people that I really don't like. And it's really nice to just give them drugs and make them shut up.
Yes. When I worked for a dentist. And so whenever I didn't want to talk to a patient anymore, I just like, oh, sorry, time to work in your mouth. Oh, I can't hear you. I'm sorry.
So true.
What was that, honey? I'm sorry.
Right.
So sorry.
Okay. So let's start off with the definition of what an anesthesiologist is and what we do. So ultimately, the state of consciousness is relative, right? And so for whatever procedure or surgery a patient is having, or maybe it's not even a procedure, maybe it's just a manipulation, like popping a dislocated shoulder back into place. Yeah. Whatever it is, the brain has such immense power to control the body that sometimes that brain needs to be settled down so that the body can be healed, right? So if that's relocating a dislocated shoulder, doing a procedure that you don't necessarily need to be all the way under general anesthesia, or if you like literally, if you don't go to the OR and have general anesthesia, you're going to die from whatever is happening right now inside of your body, right? And so, so I can't imagine back in the day before we had anesthesia, what these poor, you know, human beings did when they needed stuff that like this, right? So
God knew I could not handle that. That's why he made me come around at this time.
Exactly. And it's funny because, you know, one role that we're known for the most, because this is one of the few times that our patients are actually conscious and aware, is pregnant women with epidurals. And it's funny because when I was in my last year of med school, I was studying for my boards, and I usually studied at like Barnes and Noble, right? Always had headphones in. I was listening to classical music. That was my MO when I studied. And this woman just came up to me and she was like, "What are you studying for?" And I told her, you know, I'm like, you know, my board exam. And she's like, "Well, what kind of doctor?" And I told her, and she goes, "Oh, girl, I got 5 kids. My anesthesiologist is my best friend." I'm like,
say pregnant women either probably love you or hate you.
Yes, for sure. For sure. But it's cool because, you know, people that have a huge, now I'm not saying that there are no anesthesiologists with huge ego, but if you really want to go into it for the recognition, anesthesia is not the specialty, because more times than not, people never even know your name. Like you'll tell it to them, but they're so nervous about surgery that, you know, "Hi, I'm Dr. Fitzgerald." Exactly.
Because I feel like as an anesthesiologist, essentially what your role is getting the patient's mind out of their own way.
Yes.
I mean, that's kind of what anesthesia does. And so they're not listening to you because you haven't taken that element out yet for them. So I get that. I totally get that.
Exactly. So one of the most important, so the role starts right away, because typically when you are meeting a patient, you're meeting them about 15 minutes before you take them back to the OR, right? Depending on if you're at a day surgery place and you see patients a few hours before. But for the most part, you are meeting patients day of surgery. And it's a huge responsibility because you have this finite amount of time to establish trust and establish a sense of security in the patient, because most patients are super scared, and your job is to come and give them some relief, ease that fear, but also you can't, you have to be realistic with them, because the fact is that anesthesia is risky. And so you have this unique experience with a patient that I feel like no other doctor really has to have, where hey, this is who I am. I need to know everything about you. And here are all the risks that can happen with anesthesia. And here, you ready to go? I'm going to give you some drugs. Right?
Mix you up a nice cocktail.
Yeah, exactly. So I've never taken that burden lightly, because I really always strive to make the patient feel comfortable and just ease their heart, right? And in fact, I will say, Robert, who is Oz, who I was mentioning earlier,
behind the curtain.
I was his anesthesiologist when he had knee surgery back 2010, 2011. So he's been on the receiving end of that, and I definitely go into a different mode. I not that I'm not professional, but you see the Dr. Fitzgerald side, and my OR colleagues will call me Dr. Fitz, but I go into Dr. Fitzgerald because the fact is, I am dealing with people's lives on a daily basis as an anesthesiologist.
Yeah.
Right. So my job is because there is no one recipe, if you will, of how to put a patient to sleep, because every single person has different ailments and different medical history, right? So my job is to hear all of their stuff, all the surgeries they've had, make sure they don't have any kind of zebras, which we use that word in medicine as in like, you would never guess that they have this, but if you don't ask, it could kill the patient. For example, there is a very rare allergic reaction to anesthesia called malignant hyperthermia. And if you don't ask, hey, has anyone ever had any kind of history of high fevers or sudden death from anesthesia in your family? If you don't ask that, you could be putting a patient at risk for literally dying on the OR table. And I mean, malignant hyperthermia, it's so rare, but it kills patients. And it's one of those things. So I have this task of collecting a bunch of information and then explaining to them in layman's terms, because I hate, one of my biggest pet peeves about doctors in general is talking over patients and over their head, making them sound like, well, talking in doctor speak instead of layperson speak, So my job is to explain to them in my best ability what's about to happen and then take them on the journey. Okay. So when you were how old when you had your tonsils removed?
Oh, I don't know. I was like maybe 8 or 9, I feel like.
Okay. But you were old enough to remember, right?
I don't remember. I remember going into surgery. I remember what the operating, the big lights and it's called the theater, right?
Yep.
Isn't that okay? The big lights in the theater. I remember that. And I was trying to climb off the thing because I was scared. And so they kept pushing me back down. And this lady was just count to 10, count backwards 10. And I maybe got to 3 and then I was out.
It's so funny that you say that, because I have had that was one of the most common questions that I had was, am I going to have to count backwards? And I'm like, I have never made anyone count backwards, and I've never seen any of my colleagues make people count backwards. So I don't know,
as a kid, I don't think that they made me count backwards. I think they just said count to 10.
Yeah.
And so as a kid, that's well, why do you want me to do that? I guess I'll do it. And then you're out.
Right.
It's literally just a distraction.
Exactly. Now, do you remember if they placed an IV before you went back?
I don't remember that. I don't think that they did, because I remember I wouldn't have moved my arm because when I was 18 and got it, I still was I was walking around like this with the IV, and they're like, honey, you can bend your arm. I don't want to.
I don't want to.
So when I was a kid, I don't think that they had put me, I don't think they had put an IV in me. I think they just I remember they put an oxygen mask over me, had me count, and I was out.
Yep. So that is a common tactic to get kids to sleep, because the needle scares kids. You know,
I would have ran off that.
Yes,
that
exactly.
Been out.
Exactly.
If I'd seen it,
so more times than not, depending on the anesthesiologist, sometimes you can give a kid some oral sedation. So one of the most common drugs that we use, typically IV, it's called Versed. And Versed is the drug that works on the brain very similar to the way alcohol does. It's in the family of drug called benzodiazepine. So it works on the brain, the receptors the same way. Ambien, Xanax, all of those kind of drugs, the anxiolytic, the ones that take away anxiety, right? And so what Versed does, it's much stronger, faster acting, but it also causes what the medical term is anterograde amnesia. So basically, from the time that it starts working in the brain, which is literally 30 seconds to a minute, from that moment in time, you don't remember anything. And this is where the fun part of being an anesthesiologist starts. I'm not going to lie. I've got stories.
I'm sure you do. I don't doubt it.
So imagine, for those of you that have partaken in alcohol, and not just alcohol, but too much alcohol. That when you drink too much alcohol, that filter, that barrier that holds thoughts or holds the words back, that thoughts that shouldn't go into words. Yes. That barrier is broken, and all of the sudden verbal vomiting happens. Yeah. So imagine that to the 10th power. No, to the 100th power. So this is my favorite. I always say I love being an anesthesiologist, and I really did. Every now and then I slightly miss it, just a little, not a whole lot, just a little. I don't
just
miss
the funny part.
Yeah, exactly. But that part, and then waking patients up and taking them to the recovery room, because that's when they say some funny stuff too.
Yeah, that makes me think of all the wisdom teeth videos that go viral.
Oh my god!
Because of the stuff that people say. I guess I've been under 3 times then, because I had my wisdom teeth.
Okay,
too, and I said some funky stuff.
Oh yeah.
I did.
Oh yeah. It's so entertaining, and the more of a character the patient is, the more colorful the language that comes out of their mouth is.
Yeah.
and you can imagine as a female, when I had male patients, there were some really inappropriate things that were said that if he were to have said that to me in a bar or wherever, he would have got his slapped.
Yeah.
But you have to laugh, because literally
they have no idea what they're saying,
and no inhibitions whatsoever.
Yes.
Right. So which ultimately is good, because it takes away that fear that they're about to be put under anesthesia and about to be cut up on by said surgeon. Right. Because ultimately our job as an anesthesiologist is to keep a patient alive while controlled trauma is happening. Right. Because, uncontrolled trauma is, a car wreck or falling off of a building, or, something, that you don't have control over. But in the OR, we're having trauma to the human body intentionally to, to change something, fix something, whatnot.
Right.
So it's scary. So I have interviewed a patient. I've made them feel comfortable. I have explained the risk. One of the things that I always said was, talking about the risk, I'm like, even though the risks are rare, especially if you're a young, healthy person, like if you were my patient, I could probably, not that I ever would, just for the record, but I could probably give you a safe anesthetic, like completely drunk, because you're young and healthy. Like, and not to say that bad things can't happen to young and healthy people, but definitely the risks that come along with anesthesia are incrementally higher as you have more medical problems. So if I have the, 70 plus patient who has congestive heart failure, only 10% of his or her heart works, and has, end organ damage from being diabetic for years, like those are the patients that stroke out, that have heart attacks, that we have to resuscitate in the middle of anesthesia, middle of surgery, because they're so sick and the risks are huge, right? So whatever said patient, I've done a great job of making them understand what's about to happen, console them. Sometimes even at the best consoling, they're still super anxious, and so those people I will give more Versed than other patients, right?
Yeah.
I've also anticipated what kind of social aspect they have, meaning that if I have a patient who does drugs or who drinks a lot, and I've definitely learned, and anyone that's medical will back me on this, and you might, I don't know, maybe being in the dental field, you might have seen this, but like patients lie. Like patients lie.
Mhm.
So typically, part of my history and physical when I would talk to a patient is asking them, okay, how do you drink alcohol? And if so, how much every day? And typically when they said yes, and they would tell me, oh, just 1 or 2 drinks, it's automatically doubled in my head, right? Because a person that drinks a significant amount requires a lot more anesthesia.
Yeah.
So I have given them whatever drugs, and sometimes it's not just something to calm their nerves, right? Sometimes it's stuff to help with acid reflux, because that is one of the things. Once I make a patient go to sleep, all of their protective mechanisms are asleep too. I.e. your cough reflex, your gag reflex, all of your reflexes are basically put to sleep. Okay. So we take them back to the OR, we get them on the OR table, we put monitors on them, and we give them that mask of oxygen and get them to take big breaths of oxygen, getting them totally ready to be put under. At that moment in time, everything is done via the IV, unless you're a kid. Kids go to sleep by inhaling the gases. Okay. And the gases by themselves. So there's nitrous oxide, and then there's anesthetic gases. So nitrous is much easier and friendlier and smells better than anesthetic gases. Anesthetic gases just smell terrible. So oftentimes we would put a cherry flavor into the kid's mask so that it wouldn't be terrible. But as you can imagine, having anything come to you like a mask sometimes scares kids too. So, but more times than not, kids are the only ones that are put to sleep with gas, right? The gas passer that we're known to be. So adults, they're given drugs through the IV. Now, I like to compare anesthesiologists to pilots, okay? Because kind of what we do is very similar to what pilots do. A lot of us go into anesthesia originally because there is that adrenaline junkie in us. I know I can speak for myself. That adrenaline junkie has actually calmed down. I'm not so much of an adrenaline junkie anymore, but the idea of if crap is going down fast, all of a sudden I can be I'm that person to save the day. That
you
was cool to me.
You want to be the hero. Yeah, totally.
Exactly. So with pilots, typically bad stuff either happens on the takeoff or the landing. And for the most part, they're on autopilot throughout the flight, right?
Yeah.
Every now and then you can have a bumpy ride or, very rarely a crash in the middle of flying, but usually it's takeoff and landing. So anesthesia is the exact same way. When you're putting a patient to sleep and when you're waking them up is typically when the really bad stuff happens. And a lot of people don't understand that if you are a patient that is actively trying to die in the OR, typically it's the anesthesiologist that saves you. If there is something that's going on in the operating field, like let's say a surgeon accidentally cut an artery versus vein. So artery is high pressure, people bleed out and they die, right?
Yeah.
Vein is low pressure. It's easier to find that bleed and stop it. But if a surgeon hits an artery and all of a sudden the bleeding is just out of control and then the blood pressure crashes, you and the surgeon have to work together. But there have been so many times that we have coded a patient that the surgeon steps back and lets the anesthesiologist and the anesthesia team basically resuscitate them.
Yeah.
Right. So put a patient to sleep. You are there the entire time. You're monitoring certain vital signs, pulse ox, EKG, blood pressure, all this kind of stuff. And depending on how major the surgery is depending on what other kind of monitors you have. So long story short, if you are just having your gallbladder taken out or a breast biopsy, you're going to wake up with literally your IV in place, because that's where you are basically given all your drugs to put you to sleep, to keep you asleep and to wake you up. Not keep you asleep. The anesthetic gas keeps you asleep. But if you, and you'll have your monitors when you wake up in PACU. So PACU is post anesthesia care unit, right? The recovery room. But if you have a major surgery that requires a bunch of lines and whatnot, you're the person that's going to wake up in the ICU, sometimes with a tube in your mouth, helping you breathe, with all sorts of, lines coming out of your neck and you're everywhere. And sometimes coming out of all of your other orifices. So anesthesia is one of those things that literally so many people don't understand what we do. They just think that we put people to sleep. But we're literally constantly there every single second, monitoring everything, making sure that patient wakes up on the other end of the surgery.
Yeah.
Right?
Yeah.
Now, let's talk about OB anesthesia, obstetrics. You, at some point, you're still newlywed year. So no plan on
You're
getting
about to say
pregnant.
babies, and I'm knocking on wood.
Yep. Go knock on wood. Go knock on wood. But that is something that you have said that you want to do at some point in your future. Right.
Mm-hmm.
So first of all, have you ever considered having an epidural, or are you one of those that you're like, I want to do it?
I feel like I'm going to be the type of pregnant lady that is going to want all of the help she can get.
Fair enough.
So,
fair enough.
Does that answer your question?
Yes, it does. It does. And it's funny because the other role that we play as an anesthesiologist, as being an OB anesthesiologist, it's the same, yet it's so different because our patient is awake, and because we are not just dealing with them, but we're dealing with two lives, right? Mm-hmm. So I have to tell you a story. So the first month of doing OB anesthesia, they don't let you do OB until you've done at least a year of just general anesthesia in your residency, right? Mm-hmm. So for those people that don't understand the way it goes, you do 4 years of medical school, you get your MD or your DO, then you do your residency. But the first year of residency is called your intern year. So intern year is basically, you are basically someone's, I won't say it so the Robert doesn't have to beep it out, but and you're low man on the totem pole.
Right hand man.
There you go. There you go. But you are the person that is, you're doing all of the different kinds of medicine, but you're functioning as a doctor instead of a med student, right? So then after your intern year, you do your first year of general anesthesia, and you cannot do OB anesthesia until you've done that 1 year, right? Because OB, it's not higher level, but there's a lot more risk and complications.
The patient's awake too, so I feel like that's a whole nother.
Not every time.
Yeah.
Emergent C-sections.
Yeah.
Some of my scariest moments as a physician have been taking care of pregnant women. Mm-hmm. So my first week on OB anesthesia, literally, so a needle that goes into the back for an epidural is literally that long. So like, right. It's about 6 inches long. And I mean, it's a large needle. And when people see that, sometimes it messes with their brain, and it's like, so
yeah,
that needle goes into this tiny, tiny, tiny little space in the back called the epidural space, right?
It gives me heebie-jeebies just thinking about it.
And obviously there is a unique technique, a special technique to get the tip of that needle into that tiny space called the epidural space, okay? Mm-hmm. And if you go past that space, it's basically called a wet tap, and that basically goes into the dura. So epidural means above the dura. And if you basically pierce the dura, that is when you get these spinal headaches. And you want to try and avoid ever doing what's called a wet tap. Okay. Mm-hmm. So this technique is super important in placing this epidural. Now, of course, do I explain all of this to my patient? Absolutely not, because that just freaks them out. But
the less they know, I feel like the better.
Yes and no, because you definitely want to cover your tail as far as, risk and benefits, and because they're consenting to this elective procedure, right?
Yeah. I'm just thinking, for me as a patient, I wouldn't want you to be like, okay, so we're going to take this giant needle and insert it in this tiny little space, and if it goes past, it's going to be like, I would just be like, just do what you need to do.
Yep.
Don't tell me about it. I just want you to do it.
and of course, a few years down the road, when you're in that spot, you're going to be like, don't think about that conversation that we had with just don't think about it, right?
Yeah, now I know. Thanks.
Exactly.
Freaked out even more.
So in my first week of OB anesthesia, I not only had one, but I had 2 dads pass out on me because they saw the needle. They're watching the needle go into the back of their, baby mama, spouse, whatever you want to call. Because not everyone's married, and I ain't judging you if you are or not, but you can't always, say husband, wife, whatnot. So my after having, I'm already taking care of 2 patients, mom and baby. Now I got a third one that I have to worry about, hitting their head, passing out. No,
Yeah.
So I personally, it was my rule that I didn't let the husband or the baby daddy watch the placement of the epidural.
Mhm.
It's nice because the female can't watch it because they're facing the other way. And
Yeah.
as anesthesiologist placing it, you're behind them, right?
Yeah.
But an epidural is a very unique experience. And, I always used to say, like, if I ever accidentally got pregnant and had a baby, I would definitely get an epidural. I don't know now because my viewpoints as far as medicine in general have definitely changed over the last 10 years. So I definitely feel like a natural approach for anything is better. But then again, you don't get any trophy or blue ribbon for not getting an epidural. So this is one thing that I want to stress to women that possibly are, at your stage of life that are, going to be at that decision making point at some point. It is your choice. It's not anyone else's. It doesn't matter if your mom had 10 kids without an epidural. It doesn't matter if your husband doesn't feel comfortable doing it. You doing it, like, it is ultimately your freaking choice. And
yeah, for sure.
And it's crazy how many how many pregnant women who are at this very vulnerable stage let other people's opinions of what they should do decide if they're going to get epidural or not. Right.
Yeah. Yeah.
So this epidural is placed, and in theory, the epidural doesn't slow down labor. It just helps make it more comfortable. And it gives you just enough pain control that you're comfortable, but you feel pressure and you're able to push baby out. Okay. You've got this look like.
I am seeing stars. It's grossing me out. I don't do well with needles. I don't. And so even just it just.
But here's the deal. The needle is only there for a brief moment in time.
I know. I totally know. But it's and that's the thing is when I go to get my blood drawn, I don't go in freaking out. It's just my body literally takes over. My instincts take over. I'll be sitting there and I'll be fine. And then it'll start to get a little starry and a little hot in the room. And I'm okay, I think I should put my head down. I don't freak myself out. My body just takes over literally.
Yes.
That's the best way to explain it.
Yeah. Yeah. It's crazy. The brain is a really powerful organ that can do all of that to you. Well, so what I always like to explain to people is that needle that goes into your back to find that tiny space in your back called the epidural space is the way in which we find it, and we thread this tiny little catheter that I always like to say it's basically the width of a few of your hairs, right? And we thread it into that space. And then once it's in that space, that epidural space, we give constant medication through it. It's local anesthetic. It's the local anesthetic that you use to numb up patients' gums before. Yeah. So there's certain kinds of local anesthetics that work in different mechanisms, not mechanisms, but lengths of time. So if you have a woman who has an epidural for pain control, and all of a sudden her cervix has stopped dilating, because you can't push baby out until they're fully dilated at 10 centimeters, right? So oftentimes a woman will stop dilation for whatever reason, and will have to go to C-section, right? So if you have an epidural in place, you try and use that for the anesthetic for the surgery. I hate doing C-sections with epidurals. Hate, because can you imagine? And actually, shout out to Cassie, one of my friends who had a baby this summer. She actually used to take my class in OKC. She had that exact same thing happen to her, and her epidural was basically shoddy and it was spotty. And so literally can you imagine being awake with your arms out, a blue curtain between you and the surgical field? So literally you can't see your belly, but you can feel certain areas
Lauren, I'm never going to have kids now. Stop. You're freaking me out. imagine yourself laying there getting chopped open and being able to feel it.
I mean, seriously, like, isn't that just insane?
No.
And that happens to some women. And the problem is that when you put a pregnant woman under actual general anesthesia, so that means putting a breathing tube down their windpipe and breathing for them and completely knocking them out.
Yeah.
It's a huge risk because of all of the physiological changes that happen in pregnant women.
Yeah.
So you literally want to avoid general anesthesia in a pregnant woman unless it's an emergency. Okay. But if you have an epidural that you thought was working well, but there were some areas that it's not covering. So maybe the left lower quadrant of the woman's abdomen wasn't fully covered by that local anesthetic. So anytime the surgeon's on the right side, they can't feel it, but all of a sudden the surgeon goes over there and it's like stabbing pain. Can you imagine?
No,
it's not cool. Not cool.
I'm trying to not imagine.
So exactly. So elective C-sections, we do what's called a spinal. And essentially it's an even tinier needle. The width of the needle is the tiniest needle. The length is the same, but the width is tiniest. You go in and you actually go past that dura and you bathe the spinal fluid in local anesthetic. And it's a much deeper block. And it basically very rarely will you have problems with not having it covering, for surgery, right?
Sure.
General anesthesia in a pregnant woman. So I have to let people know this story because literally it was one of the scariest moments as a physician, as a young physician. So when a woman has a C-section, if they get pregnant a second time, they have a risk for what's called uterine rupture. So our uterus is basically where the baby, is and grows, right?
Yeah.
If the uterus has been cut into by a surgeon because they had to do a C-section, when they sew that cut up, that is an area of weakness. And so when another baby gets into that uterus and it starts growing and growing and growing, that area that was sewn back together is considered a weak area. And so we always worry about uterine rupture, especially if the woman wants to try and go natural versus let's just schedule, my second C-section. I want to have, X many babies. They're all going to have to be under C-section, right? You're limited to how many times that you can safely get pregnant though, after having C-sections.
Yeah.
So we have this woman that's going to do what's called a VBAC. So that's vaginal birth after cesarean. Okay. VBACs are done at major hospitals. Because the risk of uterine rupture for those women it's not high, but if you see a uterine rupture, that's who it happens in, is a woman that's trying to do natural birth after having a C-section. So I go in, I place this epidural on this woman and it's working good. She's ready. She's dilated maybe 3 or 4, right? So we know that we're possibly going to be here for a while. I know the epidural is working. And then maybe 30 minutes later, I just happened to be walking past the nurse's station and all of a sudden this woman who was comfortable starts screaming out in pain. Her fetal monitors change and we realize that she is probably having a uterine rupture. So literally, no kidding, it is less than 2 minutes that we crash section her. So we literally, the whole team brings her back to the OR. We put her to sleep. Like it was the scariest moment. Oh, so you're literally, the surgeon is ready to cut the moment that you put the breathing tube in this woman's mouth because it's that fast. And literally they cut her open. And I'm not kidding. This baby was doing like freestyle in her belly because the baby was out of the uterus. Are you going to throw up? Like, really? So we had to take a minor break.
We're going to talk about this, aren't we?
We are.
Let's talk about it.
Because I had just talked about how the baby was freestyling in mama's belly. And all of a sudden we see Cinthanie get really pale. Like, I mean, she's pale already, y'all. But literally, she got so pale and she said, and she just left.
I just left the room.
Yeah. So what? Tell the audience what happened, girl.
I was gonna freaking pass out. I just told Lauren this. I can watch like movies where they cut people open and whatever. It's fine. But anytime people start to talk about their birthing stories, I'm always like, yeah, this is not in my threshold of like tolerance. I can't handle this. So I'm sitting here trying to be a big girl and handle it and not say anything. And then it started to get really bright and hot in this studio room. And I'm seeing stars and freaking Tinkerbells around me. And so I did not want to pass out on camera or hit my head on something. So I just went and stuck my head between my legs.
So we should probably put a little warning, an advisory at the beginning. Do not listen to this episode
if you're squeamish. Or if baby birthing and all that freaks you out. My mother-in-law is going to hate you because I'm never going to have kids now. Never.
Oh my gosh. That literally, like, my stomach hurts from laughing so hard. Like, the break that we took was literally like 10 minutes because once you got back,
Was it really that long?
Oh, it seems like it was. Yeah,
because you guys sat here and laughed at me for 10 minutes. Yeah. Whatever. Well, have your fun.
We didn't laugh because there was a part of me that was like, oh my gosh, what if you had your own experience, like someone you loved lost their baby
but I'll never have my own experience of it now because it freaks me out. But no, you didn't hit any like sore spot.
What honestly crossed my mind was one of my closest friends in Oklahoma, Rebecca, actually her second born, she's got 2 kids, and she opted to do a VBAC, and she had a uterine rupture, and usually the babies die on uterine rupture, but hers lived. But when she found out I was an anesthesiologist, she was like, I have so much respect for you, because if it weren't for my anesthesiologist, my baby would have died, because it was the anesthesiologist who picked up on it so fast. And I started thinking, I'm like, oh, hell, I hope you didn't have, someone that you love, like, lose their baby. Because, that it does happen. It's very rare, but when a uterine rupture happens, usually baby dies.
Yeah.
So we weren't laughing while you were trying to get your blood pressure back up.
My head was in between my legs.
But the moment that you came back and you let us know what was happening, that was the 10 minutes of laughter.
It's just not my thing.
No, it's all good. But the reason why I wanted to do this episode about anesthesia is because we just got through the month of December, and December is typically when so many people have surgery, because the way health insurance is, if you've already got your premium, your minimum deduction or whatever,
flex spending and
exactly all of that kind of adulting, right?
Yes.
So a lot, like, OR is super busy in the month of December, crazy. And so people always, they know that I am a physician and an anesthesiologist, so they'll shoot me messages, like, hey, I'm nervous about this, questions and whatnot. So I'm like, we need to do an episode where we just talk about it, because it's truly like, most medical specialists don't understand really what anesthesiologists do. It wasn't until I actually did the rotation anesthesia, I'm like, oh, I just thought they sat there and read a magazine, because that's what you see more times than not when you go into the OR, because it's that during flight autopilot for the most part. Not that some read magazines, but for the most part, your senses are always like, your ears are tuned into the sound of the pulse ox, the sound of the EKG, the sound of the breathing machine, of the anesthesia machine that's giving you inhales and exhales, and like all of these things that you're constantly paying attention to. But on the outside, you just see, a guy in scrubs or a girl in scrubs with a hat and mask reading a magazine or whatever. And we do a lot more than that.
Yeah.
A lot more than that. So, okay. So one of your main roles on this podcast is to be the voice of the layperson, the non-medical person. So what kind of questions do you have for me?
So can you explain what anesthesia is doing to the body? Like, what is that process?
Yes. So actually, it is unknown the exact mechanism how anesthetic gases actually make you go into that unconscious state. Isn't that crazy? But we just know that anesthetic gases basically go into the parts of the brain. It starts in the lungs, and then from the lungs, it goes to the brain. And it basically makes it where you are unaware of everything, and it doesn't bother you that someone's cutting up your insides or your outsides. And, but anesthetic gases are, the exact mechanism of action we still don't officially know, which is crazy, right?
It's always good to hear.
Yeah.
We kind of know what we're doing to you, but not exactly, but we kind of know.
Technically speaking, yes. Yes. But, ultimately because I definitely have a lot of medical people that listen because they know that I'm a medical professional. So this episode, is not for anesthesiologists out there. It's for everyone else that really should understand what you're going through. A couple of things I do want to mention is anesthesia in elderly. It can be detrimental long term. So the older the patient is, the less anesthetic they need. And that being said, sometimes it can take them weeks to months to years to get back to baseline. And sometimes they don't get back to baseline in their mental status. And my grandmother comes to mind. She actually had a double knee replacement. And I was talking with my mom about that when I went home for the holidays, because my grandmother, she turned 89 last month, and she's got pretty severe Alzheimer's. And it wasn't until she lived in Abilene, Texas, until she was literally moved in with my parents to Waco. So she's only known Abilene. And, I asked Mom, I'm like, when do you think it really got bad? And she said, she was like, honestly, after you telling me that anesthesia can, cause some, long-term effects, I really do think that was kind of when the decline really just started incrementally going down. So, just be aware of that. Kids, we do safe anesthetic on kids all the time. And in fact, I loved doing PD anesthesia because I have a way with, getting kids to get their mind off of the fear. And more times than not, at least the OR staffs that I used to work with would always, enjoy when I was the anesthesiologist assigned to the PD dental room or the, whatever, the ENT room, that we had a lot of pediatric patients. But kids can go bad fast, especially on wake up. And so that is something that, no parent needs to take for granted, because the part of my risk and benefits talk was, the risks are small, but it doesn't matter if it's less than 1%. If it happens to you, it's 100%. So, nothing that is done in medicine is without risk. And even a placement of an IV, you can actually die from a placement of an IV. I mean, it's you almost have to try for it, but it's, nothing that we do in medicine is without risk. And, and people that are going to surgery need to have a healthy understanding of it. So any other questions that you have for staff anesthesiologists here?
What made you choose anesthesia?
So in my third year of med school, the first half was all the clinical rotations. I actually thought I wanted to be a pediatrician. I went back and forth from a cardiologist to a pediatrician, and cardiologist because shout out to Dr. Eugene Henderson in Dallas, Texas. When I was a high school student, he let me go and observe him. I was but observed cardiac catheterizations, thought it was cool as anything. So I'm like, I'm going to be a heart surgeon. Well, he's not really a heart surgeon. He's a cardiologist. But I got experience with being a clinician. So a clinician is different than a surgeon. Surgeons have clinic, but they're surgeons because they like being in the OR and operating. Clinic is you have to pre-op patients and you have to follow up with them. I didn't realize I hate clinic. And so I was like, okay, the first operating room rotation I did was OBGYN. I'm like, oh, I like this. And my dad's not in medicine, but he has plenty of clients that are doctors. And he's like, oh, you don't want to be an OBGYN. You'll never have a life. You'll never sleep. It's that. And I'm like, but I really enjoy it. I like being in the OR. And then I literally, because I had no clue what anesthesiologist did, but I took the last part of my third year, you have to do 12 weeks of general surgery. 6 of those weeks are general surgery. And then the other 6 are trauma, cardiothoracic surgery, and then an elective that you want. So I literally took anesthesia because I heard that you don't have to take as much call as you do the rest of the rotation. No kidding. That's why I took it. I'm not afraid to admit that. And I got in there and I'm like, oh, I can be in the OR. I don't have to see patients in clinic, the adrenaline junkie side of me. Like it's pretty cool because you have control over a lot of things.
Yeah.
So that's when I'm like, this is it. And out of all of the specialties, that was definitely the best one for me, without a doubt. But people ask me all the time, do you miss it? And for the most part, I don't. It's the lifestyle that I don't miss, the being on call every 2 or 3 days, because you know, unless you're at a day of like only, day surgery center and you don't have to take call. Most anesthesiologists take call their whole life. And OBGYN or OB anesthesia, I mean, you're there in the hospital spending the night. Like I don't miss that. Yeah. But I do I do miss the OR staff. We do have fun, depending on the surgeon and the staff, but those kind of things I do miss every now and then. Will I ever go back? Maybe onesies, twosies. I don't know. But I mean, I still have my license. But it's one of those things that, I feel like medical school and residency and my experience in anesthesia was necessary for me to get to this point in my life so that I can continue to follow my passion to help empower people, because ultimately I went to medical school to help people, to heal people. And that's what we're doing here on this podcast. We do it, in our coaching clients, and it just, so that's truly what my passion is. Yeah. So anything else before we wrap this awesome episode up that you almost passed out on?
Hey, I feel fine now. Thank you.
Oh, good. Excellent. And I apologize to anyone else that might have had that reaction.
Maybe don't listen to this while you're driving.
Right? For real. Put a disclaimer at the beginning of it.
For selfish reasons, I hope somebody else feels the same way so that I can feel validated.
So you don't feel like such a,
I don't want you to pass out, but I feel like a major wimp. But you know what? It's just not my thing. And I'm okay with that. I have no plans of being a doctor anytime soon. So
yeah, that's definitely not your calling, girl.
Yeah.
All right. So I definitely want to, again, thank everyone for supporting us in 2017. I want to let everyone know that what we're doing in 2018, we started off having Fitz Friday Live every Friday, and we tried some different time slots and whatnot. We are going to change that in 2018 to a once a month thing. Did we decide if we want first Friday or the last Friday? Like, I really don't care.
I don't know. We haven't decided that, but I think that we both just agreed that we better serve you guys our content when we're here like this instead of live, because there's just so many moving parts during a live, which is great, but we don't have as much control over our content, which I feel like when we are better put together, we better serve you guys. So
Absolutely.
We will Hot Mess Express it once a month.
Yes. And let's just go ahead and let's call it first Friday of every month. First Fitz Friday. Done. So every single episode we leave with a uber important message that I still like. Literally, I went to dinner with a good friend of mine, and literally the last thing I told her last night was, you're a good person and you deserve good things. And she started to cry. And it was like, so many people need to hear that message. And so Cinthanie, give them the message so that we can end this awesome episode.
Well, I love that not a day goes by that I don't get some kind of text, DM, like message saying like, I love that mantra. I have it written on my mirror. I write this on my whiteboard before every meeting with my employees. Like, it's just so cool to see people like receiving that message, not only receiving it, but like internalizing it and understanding it and living accordingly. So you are a very good person and you deserve good things to happen to you.
Amen. Well, thank you guys so much for being a part of this journey with us. And until next time, we hope you have a very Fitz and Healthy day. Bye. Make sure that you find us on social media. You can find Cinthanie on Instagram and Facebook at Cinthanie. So that's CINTHANIE, and on Snapchat at Cinthanie P. And find me on social media platforms like Instagram, Facebook, and Twitter, all at Club Fitz Fitness. Remember, that's FITZ Fitness. and on Snapchat, just at Club Fitz. I appreciate your time listening so much. If you enjoyed this episode of the Fitz and Healthy podcast, can you please go do me a favor and go subscribe at whatever platform that it is that you listen to podcasts. Leave a review. We read every single review, and we appreciate the time that you take to leave your thoughts and opinions. Now, also remember, while I am a medical doctor, the information I provide here is not intended to provide medical advice or a professional diagnosis, opinion, treatment, or services to you or to any other individual. I am providing general information for educational and informational purposes only, and it is not a substitute for medical or professional care. You should not use this information in place of a visit, call, consultation, or the advice of your physician or other healthcare provider. The information I share is not intended to treat, cure, or diagnose any disease or medical condition. If you believe you have a medical emergency, just call 911 immediately or your physician. Now, enough of that medical legal jargon. Thank you so much for listening to this podcast. I appreciate your time. Now, go live a Fitz and healthy life.